So where we left off was on this comprehensive fixed appliance, and this example, once again, is the Herbst appliance that uses this piston style of movement of the maxilla and the mandible at the same time. So this is, again, cemented on the patient's maxillary and mandibular teeth and is joined together by this apparatus right here. And if the patient opens too wide, this piece can come apart, and this happens a lot when you are doing a coronal polish and then the patient has to try to maneuver and put that piece back together. It's easily done for them, but can kind of surprise you if you don't know that can happen. So just be aware if you're polishing around these that has to happen. And if you're polishing around these, you also need to have a fluff threader to get underneath of these pieces that are cemented together and through this lingual arch wire here as well. This appliance also has this device at the palate, and it also acts as a palatal expander at times, so there can be expansion that's done with this device as well. So it is quite the mouthful for your patient to wear one of these appliances. Retainers are some of the most important things associated with orthodontics. So the retention that is necessary to do these procedures is incredibly important to keep the teeth in the position where they are right after the appliances have been removed. So we have a couple of different types here. The tap positioner you see with these little hook on the maxillary arch and the device that accepts that on the lower, and then we have the standard Hawley types of wired removable appliances on this side of the screen. So retainers can be these removable types, and this is kind of the standard type. Some of them just go across the anterior teeth, and then there are little devices to kind of anchor and hook onto in the posterior. Others, as you see in the video that I've included in this unit, will cover all of the teeth to just kind of keep everything in active retention. This type of retainer on this model is a fixed lingual retainer. So this one is going to be cemented in the patient's mouth. It is only going to provide retention for those anterior teeth. It is cemented to the lingual aspects of each of the cuspids, and it is meant for people who perhaps aren't going to be compliant, or to just allow a patient to go on with their life and not have to remember that they have a retainer in their mouth. And this photograph down here, it's kind of blacked out by the bottom of the screen, but it has a fixed lingual retainer on the maxillary teeth, which is very unusual, because if you can think about how the patient's teeth bite together, it would be kind of difficult to allow all of the cement and the wire to be accommodated by the closure of the mandibular teeth. So typically, these fixed lingual retainers will only be placed on the mandibular teeth, very seldom on the maxillary teeth, but it does happen, as you see in that photograph. This type of retainer is something called an active spring retainer, and it has these little springs, if you will, to move the teeth. So if this person had ortho done several years ago and they didn't wear their retainer, they weren't compliant, or they lost it, this could be fabricated for the patient, and these little springs can be adjusted as they move. Keep adjusting it out and allow those teeth to move back into their desired position. The Nance appliance is a fixed appliance that you may see some of your orthodontic patients wearing. So you see it has the bands on the molars, and it also has this little acrylic pad on the palate. So the Nance is used to prevent upper molars from rotating or moving forward after the premature loss of a maxillary primary molar. So these are typically placed on younger orthodontic patients. These are attached by molar bands with a heavy wire and that acrylic button to rest on the palate to prevent that rotation of the molars. So now we're going to look a lot closer at the angles classification of malocclusion, the Class 1, Class 2, Division 1, Class 2, Division 2, and Class 3 occlusion. So Class 1 occlusion is textbook. It is where the mesial buccal cusp of the maxillary first molar occludes into the buccal groove of the mandibular first molar, and it looks like this. So we have a beautiful relationship of the anterior teeth, not a lot of overlap, certainly not very much overjet. And here we have the mesial buccal cusp lining right up into the the buccal groove of that lower first molar. So this is a beautiful Class 1 relationship. Persons with malocclusion can still have a Class 1 relationship, but still be very crowded in the anterior, and we'll see that out as well occasionally. Class 2 malocclusion is where the mesial buccal cusp of the maxillary first molar occludes anteriorly to the buccal groove of the mandibular first molar. And then it breaks down further according to the position of the maxillary central incisors, Division 1 or Division 2. In Class 2 Division 1, the maxillary centrals are all inclined and protrude anteriorly, ending in a large overjet. So in this case, Class 2 Division 1 starts with an O, and the teeth protrude out in an overjet. So those all are O's. So Class 2 Division 1, the teeth go out towards the lip. In Class 2 Division 2, maxillary central incisors are inclined posteriorly, and the maxillary lateral incisors are frequently tipped labially. Lingually is what that should be. So that means that it's tipped towards the tongue. The Class 2 Division 2 are tipped toward the tongue. Here we have Class 2 malocclusion. So you see by these orange lines on the teeth, we have the mesial buccal cusp far ahead of the buccal groove of that molar, and here is the other buccal bite for this patient. And you see how those teeth are out, so this would be Class 2 Division 1. And here again we have an example of that. The teeth are pointed out away from the lower teeth, and the mesial buccal cusp is anterior to the buccal groove of that lower molar. Here's Class 2 Division 2. We have the same buccal relationship of the mesial buccal cusp and the buccal groove, but do you see how now these anterior teeth are tipped toward the tongue, and that is Class 2 Division 2. Class 3 malocclusion is where mesial buccal cusps of the maxillary first molars occlude posterior to the buccal groove of that mandibular first molar. The maxillary incisors are occluding lingually to the mandibular incisors. The mandible is protruded, or what's termed as prognathic, which has a mesial relationship to the maxilla. Here's a picture. So the person is biting together. They kind of have an open bite as well. So here is the maxillary first molar, here is the mandibular first molar, and that maxillary first molar is distal to that mandibular molar. This is what the patient looks like from the frontal view. Invisible braces. What used to be clear braces used clear brackets and lighter, finer wires and clear O-rings. So we know now that that is not the only option for aesthetic braces. Common trade names that we have today, you're probably very familiar with Invisalign. There is a brand called Orhto Clear, and Clear Correct are also very popular around this area for invisible braces. The similarities to traditional braces is that these removable trays can treat a wide variety of cases dealing with crowding, extra spacing issues, overbites, underbites, crossbites. They straighten teeth, and they're about the same cost as brackets and wires. The advantages of clear removable braces is that there's no food restriction, so the patient can eat whatever they want. They can eat chips, they can eat raw fruits and vegetables, they can chew ice if they want to. The device is removable. There's easy home care for better periodontal health, so we don't have to use the floss threaders and that sort of thing to go in and around the wires and brackets. They're more comfortable to wear. There's no abrasion on soft tissues, and they are virtually invisible to tooth, an invisible version of tooth straightening versus wires and brackets. So here we have, in each of these images, the patient is wearing clear aligners of some sort. And these two images with the arrows, they have little buttons on the teeth to help rotate the teeth into the more desired position. This tooth has actually two buttons placed on it to help rotate it back into a more aesthetic functional position. This is something where the button needs to help extrude the tooth into this pocket for the aligner. So at the end of the wear for this patient of this particular aligner, that tooth will be pulled and extruded into that aligner. Here is just an advertising for Invisalign. So the patient seen smiling, getting ready to put the aligner in, inserting it, and then wearing it. And Orhto Clear is something that they say is even more invisible than Invisalign. They say they don't have the ridges making them Orhto Clear. They're the clearest aligners available and exceptionally hygienic because they don't have the ridges that you see from the Invisalign aligners. And they do work very similarly. They just are created in a different fashion. Clear Correct is advertised as being medical grade plastic. They have antibacterial surfaces and of course a custom fit and smooth edges just like the other aligners, but the antibacterial surface is something that Clear Correct states that they have that none of the others do. We're going to get into a little bit of the DIY, the do-it-yourself ortho. There are several companies out on the market in your internet feed: Smile Direct, Candid Company, Bite, Aligner Co., Snap Correct, and Smile Love. Don't do it. Just please don't. Tell all of your friends that you cannot get the acceptable looking effect, the treatment that you want. It is a terrible idea. Some of the pitfalls, and these are not even touching the surface of all the pitfalls, but some of the pitfalls of do-it-yourself braces that are beginning with if the teeth are not moved correctly, if they're actually moved incorrectly or to an improper position, can cause permanent damage to teeth and jaws. Malocclusion from these incorrect placements and positions can cause worsening of the TMJ dysfunction in your patients. Again, worsen periodontal disease and infection because they're not seeing a dentist anyway. So if they have perio issues to start with, those issues are going to get worse if they don't see the dentist. Treatment results are not as expected. The people who are taking the impressions, the people who are putting in the aligners, the people who are making the aligners are not dentists. So people who are completely untrained are moving teeth, and that is horrifying and frightening. Having to go to the orthodontist to then fix what the do-it-yourself braces did, causing much more expense, causing surgeries, causing tooth loss, causing damage to the TMJ, does not seem like an option that I want to risk happening. Orthodontists go to school for 4 to 6 more years after dental school to learn how to do these things, and these people are ordering these off the internet, and I've seen people having to have their teeth extracted because of what happened with their do-it-yourself braces, and it's just really, really sad. Here is where we're going to end this lecture. If you have any questions at all, you know where to reach me, so please let me know what questions you need me to answer, and make sure you watch all the videos. There's a ton of them. A lot of these are going to be your checkups for this unit, so make sure you're very familiar with what's going on with putting the ligatures on, the separators, the arch wire, and all of those other how-to braces videos that are included in this unit.